Welcome, everyone. We're so pleased that so many of you are joining us for the second webinar in our series on improving the health span of older adults through nutrition. This is a webinar series that we are pleased to host with the John Mayer Human Nutrition Research Center on Aging at Tufts University. My name is Gwendolyn Jones, and I am the Executive Director here at IAFNS. For those of you who are not familiar with IAFNS, IAFNS is the Institute for the Advancement of Food and Nutrition Sciences. We mobilize government, industry, and academia to drive, fund, and lead actionable science, focusing on advancing public health. We catalyze the creation of scientific knowledge to include issuing of RFPs. Additionally, we advance science by convening experts for robust dialogue. All of our activities are grounded in our 4 core values: scientific integrity, transparency, collaboration, and public benefit. As an organization, we believe and act upon our core values and our belief that the inclusion of diverse perspectives is crucial to the development of credible science. We connect scientists, we collaborate with our science. We're all about catalyzing science so that we can deliver science that matters to advance public health, science that matters for the food and beverage ecosystem. To highlight our 3 speakers who are going to talk to us about balancing a healthy weight while meeting nutritional needs for bone and muscle health. We're going to hear from Dr. Roberts, Dr. Siglia, and Dr. Dawson Hughes. With that, I'd like to transition the presentation over to Dr. Roberts. And as I transition those presenting rights over, I will note that Dr. Roberts is a senior scientist and leads the energy metabolism team at HNRCA. Her research focuses on the dietary, behavioral, and cultural determinants of obesity, and she's received federal funding continuously since 1992. She's the recipient of many prestigious awards, including the McCollum Award and the W.O. Atwater Lecturer Award. She served as a member of a National Academy of Sciences committee that reviewed and updates to the dietary guidelines for Americans and co-founded the International Obesity Consortium for Global Studies. So with that, Dr. Roberts.
Gwendolyn, thank you very much. It's a pleasure to be at this meeting. I just want to check, Gwendolyn, that you can see my screen nicely. Is that correct?
Yes, it's all good. It's coming through perfect. Thank you.
So I'm going to talk generally about healthy weight and nutritional needs during aging. It's such an important topic, and we did a nice review which really encompassed all of the points of view of our research institute quite recently. It's in press, so quite a lot of what I'll be talking about comes from there. Some disclosures: I'm the founder of an online weight loss program. I've been the member of a scientific advisory board of a startup company interested in precision nutrition, and the AARP Foundation contributed funding to the results in press that I'm going to be talking about. To start with obesity, I think we all know that rates of obesity are going up in the United States. This graph is just a remarkable illustration of the fact that America is not the only place with problems. You know, these are remarkably parallel lines in countries all over the world. We happen to be leading the pack until 2016. I believe the United Arab Emirates has slightly overtaken us at this point, but rates of obesity are rising everywhere. And that's a huge problem for healthy aging, because obesity is the major underlying cause of all of the non-communicable diseases, diabetes, cancers, cardiovascular disease. They are all substantially entrained by obesity. So when population obesity rises, the non-communicable, in other words, chronic diseases that we think of as being diseases that affect older adults, that's what it's doing. And there's a lag time typically between developing obesity and developing the chronic conditions that it causes. So, you know, something like 10 years. So the very high rates of obesity that we see now that are continuing to rise, that have probably got worse during the COVID pandemic, we will see at the next survey, those all indicate that the future is going to be worse yet. So to talk briefly about why this is, why is the world becoming obese, and what can we do about that? The traditional theory of weight management is that it's all about calories in versus calories out. And that's because it's easy to overeat, and that's true, we all know that. The food environment fights us at every turn. We lack willpower, sometimes we lack knowledge, and it's easy to underexpend with sedentary jobs and mechanized everything. And anytime you eat more calories than you expend, you will gain fat. The result of this kind of global principle, if you like, of weight regulation is that how to lose weight should be due to eating less, exercising more, using your willpower and accountability, and setting goals to make sure that happens. And that's been the foundation of most of the accepted weight loss programs that have happened over the last several decades. The trouble is it doesn't work very well. The diabetes prevention program, which was tested in randomized trials and became the National Diabetes Prevention Program, achieved 7% weight loss in the original research trial, which in itself is not amazing, but it did reliably prevent, for example, the progression of prediabetes to diabetes. But the scalable versions have only produced about half that amount. So when you take that, you know, intensive research method and turn it into something that the population could use, the average weight loss is only about 3.5%, which is not enough to satisfy most people who want to lose weight, and it's associated with very minimal health benefits. And I think that failure is due to a number of reasons. One of them is that energy regulation is complicated. It's not just about calories in and calories out. Dietary composition matters, psychology, food culture, the addiction potential of food. All of those things are important. And I think it's really important to recognize that weight management is not just diet and exercise. The psychology and culture matters, the environment that we live in matters. Socioeconomic status is a big driver of weight management. Heritability is important, but it does only account for about 50% of variability in body fat. There's metabolic adaptations to weight loss, which may or may not be important. That's a topic of great controversy right now. And for all these reasons and more, weight management does get harder as we age. I just want to show you one slide which comes from the review that we have in press, which is a diagram of how energy requirements change with age. The blue dots are for men and the red dots are for women. And these are based on the Institute of Medicine estimates, which themselves are based on measurements of daily energy requirements. But you can see this progressive decrease from 20 years over time, an enormous decrease, which basically means that just in order to maintain weight, people have to eat less and less and less food as time goes on, you know, disappearing calories equivalent to a whole meal effectively between the ages of 20 and about 70 or so. It's also true, this dotted line shows 1,600 calories, which is the minimum energy requirements assumed in the dietary guidelines for adults. And you can see an increasing number of women and also men have energy requirements below 1,600 calories a day. And I'll come back to that because it's has important practical implications later. I'm going to switch topics slightly and then come back to merge those things together, but to talk about, well, how does nutritional adequacy change during the adult lifespan, and does this impact healthy aging? This again is a summary from our IMPRESS review. What you can see is the estimated adequacy from national surveys of different micronutrients, the percentage of the population below the estimated average requirement or adequate intake. For some nutrients, for all age groups, it's nearly 100%, which is a shocking finding in itself. Some nutrients are rarely inadequate. Other nutrients, vitamin A, C, calcium, K, all of these, we have substantial percentage of our population who routinely consume, a fraction of recommended intakes. And you can also see for many nutrients, here's an example of B6, which is that the percentage who do poorly rises with age for B6, for zinc, for calcium, for magnesium, for many nutrients. And while it's true that sometimes nutritional requirements change with age, largely these greater vulnerabilities of older adults is due to the decreasing calorie requirements with age, because what it means essentially is that you have to get all of your magnesium and your calcium in a smaller amount of food. So discretionary calories become more and more important for diluting out the diet and making inadequacies common. In the review, we also reviewed nutritional factors associated with prevention of aging-associated diseases. It was an enormous review. And this was, what we did was we collected all the information from fairly recent systematic reviews, meta-analyses, and also umbrella reviews. And for those of you who don't know, umbrella reviews are basically reviews of reviews. And what you see is the most astonishing picture of how important nutrition is for healthy aging, that you can go through virtually all of the diseases and conditions that affect healthy aging, and either healthy BMI or healthy diet has a substantial beneficial effect. That's true for frailty, sarcopenia, risk of falls, osteoarthritis and osteopenia, cognitive decline and dementia, age-related macular degeneration, cataracts, hearing loss, diabetes, cardiovascular disease, cancers, obstructive sleep apnea, chronic constipation and urinary incontinence. There's not many other diseases which are very kind of hallmark associated with aging. All of these can be prevented or attenuated with either with some combination of a healthy BMI and a healthy diet. The healthy dietary patterns in these reviews that we put together, sometimes it's the Mediterranean diet, sometimes it's the dietary guidelines measured with the Healthy Eating Index, sometimes it's the WHO's Healthy Diet Indicator. It's not possible based on the current evidence to say, for example, whether the Mediterranean diet is better than the DASH diet, is better than WHO's Healthy Diet. But in these different studies, it's clear that there's many consistencies among those different dietary metrics, and that, broadly speaking, they are somewhat interchangeable. But anyway, a very long list of ways in which healthy nutrition and healthy weight management can beneficially support healthy aging. We also did a review of, again, from systematic reviews, meta-analyses, and umbrella reviews, of ways in which nutrition and weight management can become treatments for age-associated diseases after they are diagnosed. The list is not as long, but it's still an impressively long list that healthy nutrition is a way to treat sarcopenia and prevent it worsening. Same for osteoarthritis, which is weight loss, osteoporosis, cognitive decline, macular degeneration, hearing loss, diabetes, cardiovascular disease, obstructive sleep apnea, chronic constipation, and urinary incontinence. Nutrition and weight management combined are probably the single most important things that people can do, along with exercise, for looking after their health in old age. We see this as that there's multiple causes of unhealthy nutrition, low income, willpower in the obesogenic environment, low nutrition literacy, and these decreased energy requirements were really important, but they all feed into unhealthy food choices relative to nutritional needs. Unhealthy food choices in themselves promote overeating, and the combination of unhealthy foods and the overeating that results from them produces this terrible triad of accelerated aging, obesity, and hunger, which become something of a negative cycle. I'd like to, this is just one slide before the end, to say, well, what kinds of dietary patterns are best for people to support their nutritional needs during healthy aging? We did some calculations for the dietary guidelines for a Mediterranean diet, for vegetarian diets, and in particular to look at what happens when somebody has low calorie requirements, which especially is a problem for women, but also some men when they age. And as I mentioned before, the 1,600 calories is the lowest level of dietary intake assumed by today's dietary guidelines for adults. They do have lower than 1,600 calories, but those are calculations that they do for children. If you look at these lower values, 1,400, 1,200, and 1,000 calories, you can see that as calories decline, it's simply not possible to meet the recommended dietary patterns of the dietary guidelines. It's just not possible to do that because there isn't enough food. And that's even true if you completely eliminate discretionary calories. You're not meeting your grain requirement and your dietary dairy requirement if you are meeting protein, fruits, and vegetables, for example. And that happens progressively. The difference is pretty much the same for a Mediterranean diet. A vegetarian diet seems to do slightly better because there's greater emphasis on higher nutrient-dense foods, if you like. But for all of these diets, discretionary calories disappear basically at 1,400 calories and below. I think that's a very difficult message to get across, that if you want to be healthy, what your vision of discretionary calories needs to change, that healthy calories should become the goal for discretionary calories. In conclusion, I think what we're seeing from this very extensive review, and it will be published quite shortly, and I would be happy to share the publication with the presenters to pass along as soon as it comes out. There's really strong evidence that both nutrition and weight management have crucial roles for healthy aging, and the current population norms for diet represent, that we're eating very unhealthy diets. They do represent an enormous opportunity for improvement. I mean, it's the glass half full rather than the glass half empty. But we also need to do much work to support healthy aging. We need aging-specific dietary recommendations which have not caught up with the changing demographic and the very large number of older adults we now have in society. We need screening tools for precision nutrition approaches to healthy nutrition, along with interventions. So if one person has, this aging-related disease, they're going to get a different prescription from someone with a different problem. We need public health recommendations that really reflect current science. They don't for healthy aging today. We need more research on nutritional requirements for healthy aging, because it's also true that the Institute of Medicine's data for healthy aging is quite small. And we need to grow our expertise in nutrition among physicians and government health communities to make real progress. Thank you very much.
Dr. Siglia is an endocrinologist with the primary appointment at Tufts Medical Center, where she's the director of the Metabolic Diseases Clinic at HNRCA. She serves as a research scientist in the bone metabolism team and serves as the medical director for human studies conducted through the Metabolic Research Unit. She also has a faculty appointment as an assistant professor of medicine at Tufts University School of Medicine. And Dr. Siglia is going to talk to us about acid-base balance in diet. So with that, Dr. Siglia, please.
Hi, good afternoon. Thank you so much for this kind invitation. Today I'm going to be doing the best to summarize a pretty broad topic entitled Musculoskeletal Effects of Acid-Base Balance in the Diet. And it being a very broad topic, what I've done is I've done my best to select particular points to make on both the bone and muscle data throughout the talk. I have no disclosures. So I will start with asking the question, so how does diet affect acid-base balance? And this figure illustrates the estimated acid-producing potential of selected foods. Here you see the potential renal acid load of selected food items. Here at the top are, on the left-hand side, are sort of the most acid-producing foods, which are, you can see here, are mainly animal proteins that are metabolized to sulfuric amino acids, along with grains, which can be metabolized to phytic acids. And all the way on the right are fruits and vegetables that are metabolized to bicarbonate, so essentially base producing. And the Western dietary pattern, which is really prevalent dietary pattern in the United States, you see a high intake of animal proteins and cereal grains, and a lower intake of vegetables and fruits over the last several decades. This acid-base imbalance in the Western diet can generate quite a bit of acid on a daily basis. As an example here, a 70-kilogram person can generate up to 70 milliequivalents per day of acid. And to be able to maintain that acid-base homeostasis, this acid load must be excreted or handled by the kidney. So just to briefly run through the acid handling in the kidney, the kidney can achieve this balance in part by reclaiming filtered bicarbonate, and actually also the production of ammonia, which takes up protons. And so through these mechanisms, the kidney can maintain that acid-base balance. But what happens with aging is the ability of the kidney to handle the net endogenous acid production from, say, an acid-producing diet becomes increasingly impaired. And on the right here, I have a cross-sectional graphs by Frassetto et al. That show the blood acidity and plasma bicarbonate level in individuals between, somewhere around 20 to 80 years old. And you can see that with each decade, there's a very gradual decline in plasma bicarbonate and a gradual increase in plasma acidity. So thereby demonstrating that despite this is a relatively healthy panel, you can see the overarching decline in renal acid handling. If you take this decline in kidney function with aging and you add this Western diet, what's happening over time is this slow grade progressive metabolic acidosis. And the way you would attempt to detect this is not by typically measuring blood levels of serum bicarbonate, as often this is a very insidious process, gradual, and not something on the order of a kidney metabolic, like an advanced kidney disease metabolic acidosis. So how we measure this in clinical research is a 24-hour urinary net acid excretion. And as I will now transition to discuss how evaluating this progressive metabolic acidosis, how we can take a look at the potential adverse effects on both the bone and the muscle separately. And at the end, I will attempt to sort of bring it all together with some conclusions. So starting off with the bone, bone is buffering the excess acid. So here's a illustration of two main effects of the bone. There's both a cell-mediated effect and more of a physicochemical effect. So as you see here, there are the two bone cells, main ones. This is the bone formation cell, the osteoblast, and the osteoclast, the bone resorption cell. So these sense extracellular acid via a G protein coupled receptor called OGR1 that you see here. And in a situation of a chronic metabolic acidosis, there is a suppression of osteoblast induced bone formation, expression of proteins, this is rank ligand, that binds to receptors, this is rank, on osteoclasts that actually trigger the osteoclast to increase its bone resorbing activity. Furthermore, the receptor is also on osteoclast, so there's a direct stimulation of the proton receptor. And this results, of course, in increased bone resorption and the release and loss of bone mineral as calcium and bicarbonate, so base, from the bone to buffer. But also, bone buffers the excess acid via the release of other important minerals, so including phosphate, sodium, and potassium. And interestingly, studies by Drs. Krieger and Bushinsky, very elegant work in using a mouse model, which this is a complicated slide, but I'm just walking you through this. This is a osteoclast-specific knockout of the OGR1 receptor. And what you see is in these mice, and they are shown here in the blue in these dot plots here. And what you see is osteoclast numbers and area are diminished in these animals despite lowering of pH. But in the wild type animals that are in orange, you see that with lowering pH, with an induced acidosis, the osteoclasts increase in activity. And here, these are measures of trabecular bone structure. And as you can see, the blue dots representing the osteoclast OGR knockout are showing improvement in bone volume, trabecular number, trabecular thickness, and less trabecular separation. So these are all favorable changes in trabecular bone, demonstrating that this receptor has a really important link to not only bone metabolism, but bone mass and structure. So moving to more clinical work, which is really what I do, and I, along with Dr. Dawson Hughes, together in our in our bone lab. We've done several studies, but I've selected a few just to highlight some important points. So this is a trial in 186 adults. There was a wide age range, actually, between ages 23 to 76. These individuals were randomly assigned to either a Western American diet or a DASH diet. So this is a diet, as you likely all know, rich in fruits and vegetables, definitely lower sodium. And these individuals were in a run-in period and then randomly assigned to one or the other diet. And these markers here that are graphed are markers of bone turnover. So there's C-terminal telopeptide, CTX, and osteocalcin, which is a formation marker. So resorption and formation. What you could see on the graph is that with the Western diet, there's a pretty rapid, this is a 28-day period, and you can see a rapid increase in both mainly resorption, a little less in terms of formation. And here in using on the DASH diet, you see a lowering of the markers, suggesting that this acid base potentially change, although there are many other factors that one could argue are changing here. But this was one potential, is that this rich, alkalinogenic diet is lowering bone turnover. There have been other studies in bone density and in fracture. The bone density and the fracture have been similar in that there's been favorable observational data suggesting that diets rich in fruit and vegetable intake are associated with higher bone mineral density and lower risk of hip fracture. This is a meta-analysis in 5 cohort studies. This is in about a little over 200,000 men and women age 50 and over. And what you see here is a slightly lower risk of hip fracture in these studies where it was encouraged to increase fruit and vegetable intake by about 1 serving per day. So the data observational are very interesting, but as always, it's important to look at more randomized controlled intervention studies. So in our laboratory, Dr. Dawson Hughes and colleagues conducted a 3-month clinical trial using 2 different types of bicarb supplements, which we pooled here, versus no bicarb as a form of alkali to lower net acid excretion, as you see here. And our intervention was very successful in lowering the net acid excretion, the indicator of that dietary acid load. Notably, these individuals were on self-selected diets, and the majority of the individuals were in fact ingesting at baseline an acidogenic diet. In fact, it was literally over 90%. So what we also noted was that in this 3-month interval, the alkali successfully decreased another marker of bone resorption called N-telopeptide, or NTX. This is measured in the urine, and also a decrease in calcium excretion, which is a crude measure of essentially bone breakdown. A longer study, 2 years, 2 years in duration. Here's 24 months. I apologize for the poor resolution of these graphs, but I'll walk you through them. This is a randomized controlled study using a different potassium citrate supplement. It's an alkali that is given daily. It's a capsule in 201 adults age 65 and over. And these individuals were also on self-selected diets. And what you see is over a 2-year period, this is areal BMD of the spine, and this is volumetric BMD by high resolution PQCT in the radius. This is more of a measure of 3D microstructure of the bone. And both here, in the red is the group that received the potassium citrate, and in the blue is the group that was on placebo. And you see about a 1.5 and 1.5 increase over 2 years in both areal and volumetric BMD. Notably, in the high resolution PQCT can differentiate between trabecular and cortical density, and the investigators noted a large difference, or a significant, I should say, difference in the trabecular density, not so much in the cortical density. This study by Geely and colleagues was an important study in that it was really one of the few among 3 studies really that have looked at long-term effects of alkali therapy on bone. And so overall, there's really a paucity of studies in this field. Transitioning, and I'll come back to bone towards the end. So just transitioning, let's talk about muscle, because the two, both bone and muscle, track very much together. So the mechanism of how metabolic acidosis affects muscle protein balance is quite similar to bone. So what you see in this illustration is a suppression within the muscle cell of the IGF-1, an important hormone for muscle growth, IGF-1 signaling. So a suppression of this signaling pathway inside the muscle cell. With this, eventually downstream leads to a suppression of muscle protein synthesis, the suppression of this mTOR protein. Whereas there's an upregulation in protein degradative pathways within muscle cells. And so there's this imbalance here. And with that imbalance, there's a release of glutamine. Glutamine in the circulation is then utilized by the kidney to produce that ammonia, to take up all the protons that mitigate the acidosis. So with this biological construct, you know, we could start looking at some observational data. And in fact, I just chose one particular study here, but there have been others looking at positive association here between a higher fruit and vegetable intake versus protein and cereals. This is in a Twins UK study in women. This is a wide age range. In the highest quartiles, you see the highest percent fat-free mass by bone densitometry, so, or whole body scanning, body composition. So an interesting link there, and there have been others that have shown some similar associations. Now, again, going back to the concept of intervention studies, reducing that net acid excretion with an alkaline supplement, does that impact muscle markers at all? And the one I show here is urine nitrogen excretion. Now, in a controlled feeding experiment, when you're feeding individuals a fixed amount of protein and nitrogen, you basically know exactly what they're eating. And measuring a nitrogen excretion in the urine is potentially a reasonable indicator of muscle protein degradation in terms of the difference. So here we see the experiment itself. These were 14 postmenopausal women who were put on a high protein diet. Look at their net acid excretion here, quite high. They were given potassium bicarbonate here, and you see the dramatic drop in net acid. And then at the end of the experiment, they stayed on the same diet with a basically a recovery of that net acid right back up where it was before. What you can also see the plasma bicarb and the blood acidity levels that were tracked during this intervention. What you see here in turn in the same three quadrants is the difference in nitrogen excretion. So really a negative, a huge reduction in nitrogen excretion with the intervention, which implied in this study, there were suggestions that there might be nitrogen sparing, so less muscle protein degradation with this intervention. We in our lab have done similar experiments, not quite identical, but in individuals, again, postmenopausal and men and women, 50 years and over, on self-selected diets. But as I mentioned, most of these individuals were on diets where net acid excretion was high at baseline. And what we noted was that at least when you give a bicarb supplement for 3 months, we noted for the first time important changes or improvements in muscle power in the lower extremity. This is a double leg press power measurement where you're looking at percent of the maximal leg press on this machine. And you see that in the men, we saw absolutely no difference with the intervention, but in the women. This was very interesting, a little bit perplexing about looking at the sex difference. And it has prompted additional work in this area in our laboratory, looking at muscle and it's the impact of alkali on muscle. So putting this all, sort of summarizing, I've looked at different meta-analyses to attempt to see if there was any idea of bringing all these data together and making an overall assessment. And the truth is that it's actually quite disappointing because, in fact, the meta-analysis from 10 years ago really showed and almost no evidence of anything really going on between acid base and bone or calcium balance. So it was a very disappointing meta-analysis in those scientists who really have invested a lot of interest in this work. Having said that, there were studies missing, and there has been work since. And just recently this month, I found a new meta-analysis which included many more studies. And although these scientists did not find a real connection between the acid-producing diet increasing the markers of bone breakdown and the adverse effects, what they did note was that with alkali supplementation, there is in fact at least they saw a reduction in net acid, as we have shown in these slides, a reduction in urinary calcium excretion, bone turnover, and an increase in BMD, where that Geely study I showed earlier was included among 3 studies. So overall, still some mixed findings and no clear consensus in this area. But I wanted to try to summarize some takeaway points that I want to bring to the table here. So first of all, I think that it seems very clear that if there's an imbalance between a highly acidogenic diet, where there's a predominantly acidogenic diet, in an older adult, it has the great potential to affect both bone and muscle because of the fact that the kidney acid handling is just inadequate as you age, and therefore that kind of chronic insult or heavy acid load can't be handled properly. Whereas in younger adults, in fact, with no renal disease, the kidney could presumably compensate for that excess acid load. That's what's been proposed from those that are really don't feel there's really a connection. The other important point I wanted to make was that most intervention studies to date really are conducted with subjects on self-selected diets. And unfortunately, as you all know, it introduces some variability when measuring these intermediate markers of acid-base balance and bone turnover, because many of these markers can be influenced by other factors. And so we're not studying animals, we're studying humans. There's a lot of things happening. So having a very controlled experiment is not always feasible. So we really need longer term, larger studies to evaluate sort of the longer term impact on bone mass and muscle mass, and also bone strength and fractures and physical performance and falls. So the last point I wanted to make was that the most acid producing interventions that you read about in the literature, many of them involve very high protein. And but in fact, there's a whole literature about how protein is potentially beneficial for bone and muscle. I'm sure you're all very familiar with that. So protein provides the amino acids as building blocks for bone and muscle. It results in greater circulating levels of the bone and muscle anabolic hormone IGF-1. And as we talked about, it can stimulate important pathways of muscle protein synthesis. So what if just increasing the base in the diet alone in the absence of anything else is potentially just not the right approach? Maybe we need to look at a more multi-pronged approach. And so one hypothesis that we've had in our lab is to attempt to both address the protein question and the alkali question at the same time. So what if we optimize musculoskeletal health by optimizing both in the diet? And that would be a high protein with a high fruit and vegetable intake. What would be left out of this would be, a lot of grain, for example. And so what would that do? So the hypothesis is that the protein would stimulate the bone and muscle anabolic pathways, and whereas the alkali would reduce the bone and muscle catabolic pathways. So we actually currently have in the early stages of a clinical trial where we're trying to look at testing both factors, both independently and in an additive fashion in a 2x2 factorial study design. And it's a 6-month intervention. And in this study, we focused on muscle. It's a 6-month intervention in older adults with normal or mildly impaired renal function. And these are individuals that will be consuming either a whey protein intervention or potassium bicarb. And here are the 4 groups that get randomized, and we don't have any data to show, but hopefully in a few years we will. So with that, I want to thank you for your attention.
Dr. Dawson Hughes is a senior scientist at HNRCA and is internationally known for her research on bone health. She's an endocrinologist with research that focuses on determining ways in which calcium, vitamin D, protein, and acid-base balance of diet influence age-related bone and muscle loss. She's received numerous awards and participates actively in the research community, including her current service as General Secretary for the International Osteoporosis Foundation. With that, Dr. Dawson Hughes, please.
Thank you, Wendelin. It's my pleasure to be here. Can everyone see the screen?
Yes.
Great. My topic today that I have been assigned is to look at vitamin D and what we have learned from the recent vitamin D mega trials. There we go. My disclosures are shown here. And let's jump right in. Vitamin D insufficiency has the potential to increase fracture risk through a couple of pathways. One shown on the right is by its influence on muscle mass, muscle strength, and its increasing risk of falls. On the left axis, we see the metabolic bone effects of vitamin D insufficiency. The active component of the vitamin, 1,25-dihydroxy-D, is essential for the active transport of calcium across the GI tract. An inadequate absorption of calcium leads to higher parathyroid hormone levels. It's a very potent bone resorbing agent. So a higher PTH leads to higher bone resorption, bone loss, and increased fractures. Let's begin with some common terminology here. I'm going to use the National Academy of Medicine, formerly known as the IOM, as you're aware, to consider that levels of circulating 25-hydroxy-D less than 12 nanograms per mil is considered deficient. Inadequate is between 12 and 20 nanograms per mil, and if you're above 20, you are considered sufficient. This is widely and broadly used set of definitions. Now, I want to give a little more background on how vitamin D affects muscle, because this is probably less well general knowledge. Vitamin D receptors are present in many tissues in the body, and most definitely including muscle tissue. This picture shows the decline in the vitamin D receptor number in muscle tissue as a function of age. And you can see a steady downhill regression there. So that the question becomes, is this accompanied by other aging effects? And the answer is yes. Here in this particular example, we are looking at type 2 muscle fiber stem cells. These are the satellite cells that eventually become type 2 muscle fibers. And this number declines with aging. Dr. Seglia and I did a study a few years ago in which we wanted to find out whether we could influence the number of vitamin D receptors and or the cross-sectional area of muscle fibers by administering a supplemental vitamin D. In this paired muscle biopsy study, there were 21 elderly women who had an average 25-hydroxy-D level of 18.5. So by and large, they were insufficient. They were treated daily with either placebo or 4,000 units of vitamin D for 4 months, and then had their second biopsy. In the left panel, you will see the changes that we observed in the vitamin D receptor numbers. The total number went up. Type 1, which are the resistance, the endurance fibers went up, but not significantly. And type 2 fibers, which are your fast twitch fibers. These would be the fibers that come into play when you are losing your balance and you're trying to make the adjustment to keep from falling. So in elders, type 2 fibers are extremely important for balance and for staying on your feet. And you will see that the supplementation in these deficient or insufficient women resulted in more vitamin D receptors. Did that translate to tissue area? Yes, it did. See on the right panel that the cross-sectional area of individual fibers altogether for muscle was significantly increased. Most of that increase was in the type 2 fast twitch fibers, although this was small and we did not see statistical significance for either single tissue fiber type. So now let's go to what have we learned about falls and fractures in the recent mega trials. There are 5 mega trials that have looked at falls and or fractures, and basically they were not primary endpoints. We'll start with the first one, which was the VITA study out of New Zealand. Over 5,000 adults, mean age 65 years, were treated with a monthly dose of 100,000 units of vitamin D3 versus placebo for a period of 3 years. Their 25-hydroxy-D level at the outset was 60 nanomoles. That would be slightly above the insufficient cut. And you can see in the group as a whole, there is no impact whatsoever documented of the supplementation with vitamin D on falls. They looked separately at a subset who had insufficient vitamin D levels at the beginning of the trial, and similarly, there was no risk reduction for falls there. We will go now to the next mega trial, and this was a mega trial with over 25,000 participants, mean age 67. Note importantly that the initial 25-hydroxy-D level in this large group was 30.8 nanograms per mil. They were very sufficient in their status with regard to vitamin D at the outset. Treatment with either 2,000 units of vitamin D3 daily or placebo, and they had a couple of other options in there. One was the randomization to omega-3 or placebo, but we are focusing on the vitamin D intervention. And you can see from this graph that there was no hint of any impact of vitamin D supplementation on falls. Let's go to the third big trial. This was Larry Appel's adaptive design trial that was published fairly recently. In this trial, 688 adults age 70 and older were enrolled. Their starting 25-D levels had a wide range of 25 to 72 nanomoles per liter. Most of them would have been in the sufficient range, almost all of them. They did a 2-year intervention, a 2-year period with 4 different arms. They had a 200 unit, 1,000 unit, 2,000 unit and 4,000 unit arms. And at 2 years, they looked to see what was most promising, and we're going to pick that dose and go forward with it and the 200 unit so-called control dose. Most promising at 2 years was the 1,000 unit dose. So they carried 1,000 units forward for 2 years here. And you will see, while it looked promising initially, in the long run, it had no impact on falls. So this is 3 for 3 that are going completely null. And basically, that's been the story. So let's now look at the very few components or information we have from mega trials on a fracture. That VITA trial I mentioned initially from New Zealand, with its 5,000 plus people and 100,000 units a day dose, did not see any effect on fractures over the course of this study. Katie Call has reported this out, and these were verified fractures. And so that was very disappointing, but consistent at least with the observation of no effect on falls. The very recently published Do Health study was a 5-site study conducted in different countries in Europe, most of the participants from Switzerland. They were 70 years of age and older. They looked at several interventions, vitamin D3. This was modeled after the VITAL study in terms of the vitamin D and omega-3 arms. They also added a strength training. This is a home-based, simple exercise regimen versus no strength training. Intervened for 3 years. The baseline 25-hydroxy-D level was above the cut for, so it was in the sufficient range at 22.4 nanograms per mil. I'd like to point out also that their SPPB, which is a physical performance battery, revealed a score, an average score of 12 out of a possible score of 12. So these were your mountain climbing Swiss seniors, not the frail ones sitting in the house, basically. So what did this trial reveal? They had 256 verified non-vertebral fractures documented. And if you look at the red marker here on the slide, non-vertebral fractures, there was really no impact whatsoever of vitamin D versus no vitamin D on fracture rates. The same was true for the other 2 interventions. And so it was disappointing that once again we see no impact of vitamin D supplementation. So I would like to, at this point, make a couple of comments about these mega trials. In addition to the point that they've been consistently null for vitamin D supplementation. Let's take a look at where these trials have been conducted in relation to vitamin D status in those locations. The circles indicate the US, Europe, and New Zealand, and the population in general is sufficient in those regions. Unlike much of the Pacific Rim and Russia and many large population areas. So they do not represent global outcome at all. And we heard from Sue Roberts earlier that there's inadequate vitamin D from dietary sources, but vitamin D supplements in the United States are big business. Rising stakes, look at the increase in supplement use up through 2009. I just got a figure for 2017, and it has jumped from the $425 million in annual sales to $936 million in annual sales. While all of this selling has been going on, these mega trials in the United States were recruiting. So it's no surprise that the starting levels were pretty high in these trial participants. When you look at this depiction of physiologic function in the context of these vitamin D supplement trials, you can appreciate that at the starting level, people were already at the optimal function level, depicted by the little letter A here. And so there was almost no room for improvement. Plenty of downside for overshooting, and that's been documented, but there wasn't much chance of seeing anything when these participants were recruited without reference to choosing people who were insufficient at the outset. So my second comment is this. The mega trials were looking at vitamin D alone in terms of the falls and fractures. They did not include calcium supplementation. And I'd like to point out, I think this vitamin D enthusiasm was triggered in large part by the Chapuis-Meunier study back in 1992, they enrolled over 3,000 nursing home residents, mean age 84.6 years, into a trial in which they treated them with modest doses of 800 units of vitamin D3 and 1.2 grams of calcium daily. The baseline 25-hydroxy-D level in these nursing home residents was insufficient at 16 nanograms per mil. Insufficient. Calcium intake was inadequate at an average of 511 milligrams per day. So with this modest supplementation, the probability of hip fracture was significantly lower in the supplemented compared with the placebo group for hip fracture, shown on the left, and for other non-vertebral fractures, shown on the right. A few years later, in 1997, we published findings from our Stop It trial, in which we had used modest doses of vitamin D and calcium, 700 units and 500 milligrams daily versus placebo, daily for 3 years in a group of healthy older adults. And we too saw a significant risk reduction for fracture. So I would like to point out the findings from a recent meta-analysis of randomized trials with D alone, shown on the left, and with D plus calcium, shown on the right. In the upper segment of the left-hand panel, we are looking at the performance of D alone on any fracture. In that lower segment, we see, if anything, an increase, not quite significant, but close, for fractures with D alone. In contrast, in the right panel, for any fracture, there was a 6-point risk reduction. And for hip fracture, there was a significant 16% hip risk reduction. These are summarized here just so that you can see them a little more clearly. One is the combination of calcium D was highly effective. So another reason these mega trials have been null is obviously that they use D alone, it appears. So let's talk for the last few minutes about attaining vitamin D adequacy. We know that food sources of vitamin D are quite limited. Sun exposure is important. Supplements are often required, particularly in winter months, in the highly populated temperate zone, where winter sun exposure is ineffective. So let's take a quick look at what current thinking is about vitamin D supplements. How much, how often, and under what meal conditions. So let's go back to that Yao meta-analysis I just showed you. And this is the calcium and vitamin D combo, but shown in the blue highlight there is the vitamin D dose in these calcium plus D trials. And you can see that they were consistently given daily, and they were in the range of 400 to 800 units per day. Most of them used 800 units. Seeing the efficacy of that and lack of efficacy of higher doses of D given alone, I would say that this range is the sweet spot, and I think 700 to 800 is a good guesstimate of what is needed. It's certainly consistent with the National Academy of Medicine. How often? This is a quick little look at the impact on the circulating 25-hydroxy-D level of giving vitamin D supplements daily, the same amount, but given on a weekly basis or on a monthly basis. You'll notice that on the monthly plots here, there's a lot more variability. There are a number of individuals who had achieved quite higher 25-hydroxy-D levels on this. There's also a body of evidence that many of you would, I hope, be aware of, that high infrequent doses can increase risk of falls, and a high annual dose of vitamin D will increase risk of both falls and fractures. So I think to keep this simple, daily to weekly dosing would be the longest interval I would choose. And finally, under what meal conditions? We looked at this a few years ago to see vitamin D is a fat-soluble vitamin, and there was very little available on its absorption and the effect of different conditions on absorption. So we did a little study in 62 healthy older people. It's really a D tolerance test where you give 50,000 units of D3. We used a deuterated, spiked D, spiked with deuterated D3. And then at 12 hours, you look at the increase in the parent, the cholecalciferol level, the parent vitamin D level in the circulation. And you will see that under these three conditions, no meal, high fat meal, and low fat meal, that the winner for maximum absorption was taking the D with a low fat meal. So I think that's reasonable. We did a follow-up study and saw that and confirmed this basically. So I would like to wrap it up with the statement that vitamin D supplementation in adults with insufficient and deficient 25-hydroxy-D levels is very important for bone health, and that vitamin D, together with calcium supplementation, or even better, with an adequate calcium intake from food sources, is more effective for bone health than vitamin D alone. The null mega trials do not alter the importance of meeting vitamin D and calcium intake requirements. 800 units of D3 is sufficient for the general population. It's consistent with national recommendations, and there is really no call for these high dose D supplements from the perspective of bone health. Thank you very much for your attention.
Great. Thank you so much, Dr. Dawson-Hughes. I think everybody's now thinking about their vitamin D and are they taking it with calcium and the timing, etc. As we've got a few minutes here, just about 10, would like to invite back on the screen Dr. Roberts, Dr. Siglia, and Dr. Dawson-Hughes. Fantastic. If you guys could turn your cameras back on and we can get started with a few questions. I'll note we've got a good number of questions showing up already. So let's start with, oops, I closed the button that I needed to have. Let's start with Dr. Roberts, and the first question would be around, you know, with aging, there is a decrease in physical activity, right? And there's an increase in physical disabilities that go on with aging. How does that change the nutrient requirements?
I think that's part, you know, certainly physical disabilities influence energy requirements. You know, if you can't be as physically active, that will be one component of a decrease in calorie requirements. It's not the whole explanation for a decrease in calorie requirements, because you have a decrease in metabolism as well. There's some evidence, for example, that you can offset low physical activity with somewhat higher protein intake in preventing muscle loss, but I wouldn't say that that's real strong science at this point. So I think there's just a lot to be learned. You know, if you start poking around in the data, it's just shocking how little research there is on healthy nutrition for people over 70 years of age. So I think, you know, we've got a lot of catch up to do. The demographic changes have happened more rapidly than the awareness of what we need to do to keep that population healthy.
Great, thanks. Next question will be for Dr. Siglia. And this is an interesting one, as you were talking about the acidic producing nature of, you know, meats, egg yolks, etc. There's a question around plant proteins, okay, whether as well as other alternative protein sources like Beyond Meat or Impossible Burgers and those proteins. Do you know if those would be considered low acid producing proteins?
So actually, if you look on that particular image that I had shown, the vegetable-based protein does not have as much, does not carry it because of its composition. It doesn't carry as much of a acid load as the animal derived protein.
Okay, great, thanks. Then for Dr. Dawson Hughes, when you think about the role of vitamin D and the supplementation component, is there danger in reducing the dose of vitamin D supplements from, say, 2,000 international units down to 800 international units? I think this question's really getting at increasing over age and time, as well as hitting upper thresholds. Or actually not quite at 2,000, never mind, that's not an upper threshold. But go ahead, please, reflections on that.
Yeah, the trials I showed you that illustrated benefit for bone did so in older people, and they were testing doses in the 400 to 800 units per day range. To me, that's it's implicit that those levels were sufficient to get the job done in older people. So I don't think we have evidence of harm of a 2,000 unit dose in terms of fractures, but there's also no evidence that it's better than the NAM recommended 800 units a day. So I would simply say keep it simple and just drop down to the 800 to 1,000 units in there.
Great, thank you. So let's go back to Dr. Roberts. And the question is, looking at the source of the data that's talking about nutrient inadequacies below the EAR, and did that include nutrient containing dietary supplements? It looks like it didn't, but yeah, please.
It does not include dietary supplements. You know, maybe some people are making up their nutritional levels with supplements. You know, I mean, historically, supplement research has not shown terribly promising results when you think about multivitamins. I mean, Bess's research is extraordinary and important for demonstrating specific effects. So no, the supplementation was not included in that. And, you know, dietary guidelines do not recommend supplements at this time. So we were looking at this from the perspective of public health. I don't really know what the right answer is about supplements either. I mean, are we really going to become a nation that says it's impossible to get your nutritional needs from food, therefore everybody over 60 should be taking supplements? I don't, you know, it has, those are big questions.
Indeed they are. So thank you. Dr. Siglia, one of the questions is around potential outcomes of your research on acid-base balance and the development for alkali supplements or drugs for the treatment of osteopenia or osteoporosis and sarcopenia. Is that kind of where you're thinking some of this could start to go?
Yes. So the idea would be that this, if in fact we detect improvements in bone mineral density and bone structure with reducing this net acid excretion from dietary consumption, it could in fact have major implications for osteopenia, osteoporosis, and sarcopenia, and the sequelae of that, which are fractures, falls, and disability. Yeah.
Okay, great.
That will require long-term studies, more work, because right now it's really much in the shorter-term markers at this point.
Great, great. Let me go next to Dr. Dawson Hughes and ask, and this has to do with some of that last data that you were sharing around taking vitamin D supplements, excuse me, taking vitamin D supplements in high fat versus low fat, and asking about vitamin D with fish oil pills.
Interesting, because that would be a high fat pill, wouldn't it? Yes.
Okay.
But you don't take the pill by itself in general. So if you were to take the supplement even with the meal, you would be okay. That's what we actually used in the study itself.
Okay. Okay. Great. Great. Then let's see. I'm looking at the time to try and balance it. I think we can maybe do one more round of questions here. So for Dr. Roberts, could you talk about nutrient requirements to prevent osteoporosis?
I would like to pass that question to the other experts on the panel, Beth, for example.
All right. So I would say Dr. Siglia and Dr. Dawson Hughes, thoughts on nutrient requirements to prevent osteoporosis?
Well, I'll start with the calcium and vitamin D components there, and meeting the National Academy of Medicine guidelines is a very good place to start. I'd like to point out that while we can store vitamin D in our fat tissue, if we don't get the calcium requirement every day, then we are triggering bone resorption on those off days. So the calcium you ate yesterday is not going to help you tomorrow. So you need to be consistent with the intake, particularly of calcium.
Great, thank you. Dr. Siglia, any comments to add?
Only that I think when it comes to protein and other aspects of nutrition, I think the data are not as ready for clinical practice, prime time recommendations. So what we do in our clinical practice is really work to at least maintain weight and have a adequate protein to the RDA at least, and there's some data to suggest that maybe higher protein intakes might be beneficial. But again, I think more work is needed in that area.
Great. So then I'll ask Dr. Roberts just to kind of expand briefly on where you would like to see more work go, perhaps even in your own lab, in talking about what's needed for older populations.
I think the big next push needs to be getting interventions that work. You know, identifying, based on the research that we know today, what public health initiatives from screening to intervention to monitoring can we put in place to support healthy aging? When do they need to start? I mean, I think it's, 65 is way too late. Are we talking about, supporting healthy aging from age 40 onwards, from age 50 onwards, but, substantially earlier when, people start to see the writing on the wall and they start to get concerned about wanting to preserve their health as they get older, and targeting interventions and trying to see what we can do to individualize those interventions with precision nutrition approaches as well. But just general healthy interventions for everyone would be a great place to start, and we really don't have that. We've got disease specific things, but that's not the same as trying to do a broad brushstroke and prevent healthy aging with interventions at the public health level.
Great, thanks. So with that, I think that is a great question. I'm kind of calling out the need for more research to begin wrapping up our time today. Want to note the third webinar in this series will be on April 15th. Where we're going to hear about delaying age-related eye diseases. That, similar to this, promises to be very robust and full of lots of new information. Additionally, as we close out, I want to thank our speakers today, Dr. Roberts, Dr. Siglia, and Dr. Dawson Hughes, for sharing their work. Lots of good questions. I know we could not get to all of them, but also want to thank all of the attendees for dialing in and participating. We had lots of interest in, is this webinar series going to be available? Yes, we are going to be posting it online, targeting in about a week. And please know, if you have any questions, you can reach out to me directly or follow us on our social media channels, including Twitter and LinkedIn. So with that, thank you, everybody, and I hope you have a good rest of your day. Bye-bye.
Thank you.
Bye, thank you.